So for the men, we still love you very, very much. We just needed a girl moment. And so, colleagues, it gives me great pleasure to welcome Prof. Busim Mkaka, who is going to be chairing this particular session, and she is the president of our College of Anesthesiology. Over to you, Prof.
Okay. Hi, colleagues. I hope you are refreshed after today's lunch, and I hope you won't fall asleep. Okay, so this session is the second last one of this conference, which has been highly, highly productive, and it gives me great honor to chair this session. So just to tell you what it's really about, so it follows on plenary 4 and 5, where we discussed a few issues under education and assessment, as well as reimagining leadership and what a letter to leaders and future leaders would look like. So we've got 4 speakers. 2 of them will cover the first plenary, and 2 of them will cover the second plenary. We also have rapporteurs who will bring back feedback from all the discussions that were had. So if you allow me, I'm just going to give you a brief summary of what was discussed in the 2 plenaries. So under leadership in education and assessment, we discussed very interesting issues. One was whether a global standard in medical education and assessment should be looked at. And I got the feeling that people are not for that, especially with regards to the possibilities of immigration. We maybe could look at a regional standard, but that will come out in the discussions. There were lots of discussions that touched on context in education and assessment and how important that is, especially where there's an issue with capacity in the different regions in Africa. We also talked a little bit about power dynamics with assessment, and I think it links up very well with transformation, which we're not really discussing, but it's important as well. Then we spoke about COVID and how we adjusted to COVID. So one of the issues is, did we lose anything from that, and what can we take forward? How can we improve in terms of the offering, especially for online exams? Then we got some best practices shared from different colleges as well as from universities like Botswana, which I knew. And one of the best practices that we all heard about was the need for postgraduate training in our universities. We also spoke a bit about work-based assessments and entrustable professional activities, how we would implement them, and whether they would totally replace our exit exams. So I'm hoping that that discussion will come out as well. We spoke about resources like single best answer banks and sharing of these resources across Africa and with overseas institutions. So that is all that I'm sure there are more issues, but just to give you a primer for the discussions that will come. Then in terms of leadership, we heard extensively about the importance of leadership in all spheres, especially the attributes of a good leader in academia. Also, there was a bit of discussion about incorporating leadership training in medical training. And I'm thinking that maybe that should be something that would incorporate in how we test the EPAs. So without further ado, I'm going to call on the speakers to come down. So I'm going to ask Prof. Alan Davison, who is the president of the College of Pediatricians, as well as Prof. Philip Mshebalwa, to come first. So the 2 initial speakers will reflect on the first plenary, which was on leadership in examination and assessment. Welcome. Take a seat. You don't take a seat.
That's okay. It's all, okay. It's all good. I'll do as the chair directs me. Thank you, Prof. Mkaka. Yeah, that's me. I am your first responder, technically, rather than a recapper. So you'll forgive me if this is a lot about style rather than substance, but I hope that it resonates. So I want to start with referencing Prof. Rana. Maybe if you add my references together with Vanessa's, come up with a joint score, we could share the Wellness Prize, Vanessa. So he spoke about non-judgment. I want to link that to compassion. Jimmy Formunk told a story at a college grad about 7 years ago, which I Googled it straight away because it's incredibly powerful. I call it a full munkism now because I cannot, for the life of me, find a reference anywhere else. He spoke about activism in medicine and challenged the college to be activist. He referred to a sex worker being seen with a work-related problem by a rather unsympathetic doctor. And he used this phrase, she knows the risk she runs, she just can't run from the risk, which I love. So I'll take the first slide. Oh, in fact, I can do it here. So the questions that I asked myself through these 2 days is, how do the colleges, all of our colleges, show leadership? And second of all, using a pediatric prism, I'll reflect very briefly on how do we show leadership inside our colleges. So to the first, I've given it to you in a word, it's activism. It's basic stuff. Sitting with registrars in a council meeting the other day, they say they want posts. Wickedly, I think to myself, you know, those guys going home at 9 a.m., maybe we can free up some of those posts, right? Because it's tough to get work, right? We need to promote wellness. We've spoken about this. Wellness just in terms of our workforce, but also we know that wellness in our workforce means wellness in our patients. And the other thing for me is we need activism about changing the narrative between those who teach in the universities and in the hospitals and the colleges, because quite often, and it hasn't come out in these 2 days, but I'm going to wash partly my dirty laundry. There's a them and us sense sometimes. Sometimes there is, Johan. Sometimes the guys on the ground, the consultants, they talk about the college as them, and then I say, guys, we all one. We literally are all one because it's the same workforce. And I think we need to encourage in heads of departments, in deans, a strident conversation about how we're all interlinked. That has to fit together, though, with other parameters, such as the universities recognizing this work as, you know, a absolutely, you know, let's call it an A-rated teacher and an examiner as being the same as an A-rated researcher. And we know right now that's not true. So what about leadership inside the colleges? Again, give me the next slide. I have very few slides. Go ahead, guys. That's it, right? It's in a word, teamwork. But teamwork is easy. Teamwork can just be a stock phrase, stealing from Lionel, a conversation just now. Actually, it's about accountability, transparency, which is why, for example, we had the registrars in our council meetings, and it's about listening leadership. We have to promote the juniors. That's actually quite tough because you need a balance between senior and junior guys. You need to bring people through. We need succession planning. We need to be thinking about that. We need, and this has been one of our, well, I mean, arguably, you know, pediatrics lagged to some degree, but we went through a very intentional, a process of creating intentional diversity about a decade ago. Before we had the decentralized exams, which I'll get to in a minute, which were actually a real bonus. That was the COVID-related dispensation, a real bonus to our processes in that respect. But we were counting heads. You have to. Gender, ethnicity, geography, you've got to look at those things and include people intentionally. And sometimes it's a little bit awkward. Sometimes the conversation is a little bit awkward, but actually it's important. You got to do it. And then we've spoken a lot about training for the teachers, training them in terms of teaching, in terms of assessment, in terms of management. So in terms of our own college, for sure, our resource, our most important, like yours, the most important resource is people. And the MCQ process showed me that is going from, we had a very solid part 1 exam. So we have a lot of exams, like America. He and I carry some interesting baggage with all our subspecialty exams and so on. So the diploma, the part 1 and the part 2 are the sort of main flagships, and we had a part 1 MCQ exam that goes back almost a decade. But bringing on the part 2 and then the DCH has been an enormous job, and it's only possible because of people who've really dug in and worked as a team. I will say one thing though, often it's the same people. And that's something we got to, again, about that intentional diversity. Sometimes it's not about gender or ethnicity or geography. Sometimes it's just about somebody else needs to do that job, not that person, because that person may be very good, but they're doing too much. And then came COVID and a decentralized exam, an idea we stole from the physicians, bless them, which was wonderfully successful. Actually, in terms of broadening the faculty, because now there's so many more examiners that need to be impaneled, deepening, but they all need to be trained now, so it's more work, right? Deepening our diversity and onboarding centers. Chris Sutton from Polokwane spoke the other day in our council meeting about how doing exams there, because they'd never had an FCPA exam there, was, a big developmental experience. So we have kind of, for those in the region, historically 6 big centers where we ran exams, and they were all centralized. And now we have opportunities through all these processes to work differently. And the last thing, of course, apart from people, it's about relationships. And in that respect, our relationships with our community are strong, and with the registrars, despite all of the difficulties. The other thing we've had to tend is the relationships with the professional societies, because our subspecialty exams really depend almost entirely on them. And standardizing those exams, the whole bouquet of 14 to 15 subspecialty pediatric exams, has meant a lot of legwork, a lot of actually making sure that they're all doing almost identical processes, so that there is standardization for the students who are on the receiving end of all of this. But if you listen to my narrative, you can stipulate to the fact that people are tired, okay, for sure, which brings us back to activism. So I'll take the last slide. So clearly we need to look after our people, and probably as a region, we need to find ways to do that together. Now, I was chatting to Prof. Marjorie at lunchtime. So the question is about this wellness. What's it all about? We've had, I think, a lot of discussions quietly off the record about the question of stress, managing stress among young people, the fact that people have different approaches and attitudes and so on, now that we might have had. And we have to be careful about that, and making those kind of comparisons. But what the most compelling thing for me in the last couple of years is my registrar started a registrar wellness initiative. Now, you would imagine that what that entails is yoga, going to the gym, doing a bit of an outing, etc., etc. Not at all. They came up with this. I'm on naught, so I'm done. They do things for kids, so they get their wellness. Excuse me, by giving. Thanks.
Thank you so much for sharing those. The next respondent is Prof. Mshebalwe, Secretary General of the West African College of Surgeons. You're welcome.
Thank you very much. I'm so pleased to be here. I'm a pediatric surgeon from Abuja, Nigeria. We had a ladies session, an elder session. Now we have a pediatric session. So I think that works well. I'm also going to follow up on leadership in assessment and examination. And most of my talk is going to be based on the discussions we've had since morning. I'll start by saying that where I come from, we say, you don't tell the crocodile how ugly it is until you cross the river. So, and when I was in training, I felt in the West African College of Surgeons, some things were a little bit ugly, and I was very eager to tell them how ugly they were. However, some things changed. We changed the rules, and then previously the Secretary General gets his anointed successor. So I'm the first person that was elected by the general body of fellows. And all of a sudden, I'm now the head of that ugly crocodile. And I had some few things I wanted to change in the college, talking about leadership and assessment. Our pass rates used to be about 30%, and many people were very proud of that, because 30% means we're a tough college. I thought that was unfair. And our college is run by 8 faculties, and I got the faculty chairman. When you talk about Africa again, talk about age, all of whom are older than me. I sat them down in a room. I said, I think we should improve on our pass mark. And I suggested 70%. Somebody like, do you have any basis for 70%? I said, I don't, but I think it's a good number to aim at. And they said, I'm planning to lower standards. I said, no, maybe we should just improve quality. In about maybe 4 years now, we've gotten to about 50% on the average. Some are doing a lot better than that. And I think that is how, you're talking about power, you need power to make change. So I think I used some of the powers I had. And in this base, one of the things we need to change was our examiners and the mindset. Some people could be examiners for life. And we have a pool of about 10,000 or more fellows. Once you are 5 years or more, you're a potential examiner. We have a rule that if you attend a train of trainers course organized by the college, every 2 or 3 years that is run, then you observe and the exam, you're eligible to become an examiner. I'll also piggyback on the question bank issue. Another criteria is that you must supply questions to our bank. So that's how we get our pool of questions. Many people eager to be examiners, and then they can contribute. So we have a large pool of people waiting who are going to be part of our exams, and that improves our number of our question bank. But that wasn't enough. There are many things we want to change. I listened to change today. One of the biggest themes I'm taking from today is drivers of change, agent of change. But after a couple of years in the job, I think we need to make haste slowly. I've discovered that some of my grand plans do not always work out. Yeah, I'm happy to have Professor Donko here as the president. He has two main themes he came along with. He came about inclusion of younger fellows and inclusion of ladies. I don't know how it will sound that I say I don't believe that we should carve out a niche for ladies. I never believe in that. Professor Donko believes so strongly. But allowing him to have his way, we have seen that more ladies on our boards, in our council, in our examiners, have really made a difference. So those are some of the changes that we are trying to make a little bit slowly. We now use an e-log book for formative assessment, and then we have a feedback every 3 months. This is one area I think is really very weak, that today I was surprised to hear that other colleges are grappling with it. Must we wait till the end of the training to decide who is good? If we could improve in our formative assessment, maybe work-based assessments in our college, maybe that would have made a difference. Then all our fellows have to do dissertations. And it's a rigorous process through the form of proposals and assessment. You have 2 assessors who must look through that work, one of which must be an examiner at your exams. And then the candidates still fail. And I'm like, why should anybody fail if you've gone through maybe a year of research with him, gone through every methodology? And once again, I called the chairman, and I said, I think that all the questions you need to go to ask the guys in the exams, give them 6 months beforehand. Let them go through them, review them, and show up in the exams. Anybody that can't satisfy you should then fail. And there was a big uproar. But again, I used my powers, and then since then, hardly anybody has failed dissertation. The next change I wanted was in our single best answer. It's a screening test to go for the clinical aspect of the exams. And we do our exams every 6 months, in April and October. And once you fail that screening test, if you come for the next exam, you have to do everything all over again. And I'm like, do you think in 6 months they've forgotten everything they've learned? Maybe they can bank that pass they have and come for the next exam and only sit for the clinical exam. Unfortunately, that idea was thrown out so quickly through the window. I'm surprised I was still left in the room. And I'm appealing that when we go home, Professor Donko will reconsider that part and allow our candidates to, 6 months is still, they can still have the knowledge of what they had. Maybe we should let them come for their clinical aspect of the exams. One of the things we look for when we're driving change, especially in the West African College of Surgeons, that we hardly get funding from any source except fellows' dues and candidates' examination dues, is cost. There are many good grand ideas that I think we can put and implement. When I look at the account balance, I have to say no. We have to at least justify the resources we have while we're maintaining quality and standards. A big thing from the leadership discussions today I've heard is about feedback. And I think that's one of the biggest areas we don't get good feedback. If we give feedback to anybody, it's the candidates who pass the exams. When they pass, we get them into a room, tell them they did so well and how to do better. Although the chaps who are outside and didn't make it, is one area I think we still need to work on. I was thinking of individually mailing a summary of their results. Sometimes per session, we have about 2,000 candidates. So maybe if we have a pass rate of 50, I'll be sending emails to 1,000 candidates saying you need to work harder. I'm still thinking of a more practical way of giving feedback to our trainees. For our examiners, definitely we get feedback from candidates, and we try and tell them that this is the feedback we get, and maybe we can get some improvement. Talking about resource allocation, which is something leaders need to consider, we have about maybe 60 institutions that are involved in training our candidates, and not all of them can have the resources to the level that we require. Now we have this concept where they can have joint accreditations, and the candidates and the trainees can go between two centers to improve the quality that we get. Finally, I want to say that the West African College of Surgeons, though we are 63 years, we have moved very fast and we have achieved a lot. I think the reason is because we have done it alone. We have done it little external influence, very little. We pride ourselves in looking inwards, and we have moved very fast. But this is popular saying that if you want to move far, now you have to move with others. So coming from this meeting has occurred to me that, hey, no matter how fast we're moving, to move very far in an objective way, we need to collaborate along the continent. And I looked at two areas of collaboration from this discussion. One, I'm going back again, is question bank. How are we sure of the validity and the quality, discrimination of our bank if we don't expose it to others and test it and know what's happening? And then, of course, if the same diseases we're treating, why not share amongst ourselves? This is one of the things I'm definitely going to take back to the council to consider in the West African College of Surgeons. The last thing is the training of the examiners. We have our in-house training, we think is good. But yesterday there was a discussion about, COSEXA has one semi-formalized one. Today there are some certificates being considered for diplomas. I think this is a strong area of collaboration, especially in the virtual world, where we don't have to travel to participate in all these courses. So in closing, I wish to say this meeting, African meeting, global meeting, has really had an impact. And there's a real need for cross-collaboration amongst leaders of postgraduate colleges in Africa. Thank you.
Thank you very much. I think some of the comments you've made are very good and relevant, but I think some of them will come up in the discussions from the rapporteurs. So I want to call on Prof. Moodley, who's the head of public health medicine at University of Pretoria, to come down. You gave me a heart attack there.
Hi, good afternoon, everyone. I should say neither of those things are true. It's not Prof. And I'm not the head of public health medicine, but I am from the School of Health Systems and Public Health at UP. So we'll just wait for the slides. Okay. So this was a breakaway session on leadership in examination and assessment, and it follows on very nicely from what Prof has said there, because our first slide is about collaboration. So I think the main outcome of our breakaway session is that the feeling that we need to form a Pan-African working group on assessment and training. I think we've kind of touched on superficially what each of the colleges are doing, but there was a feeling that there needs to be sort of a more in-depth look into that, so we understand what our shared missions are, and then I think from there one can identify potential areas of collaboration. And in particular, we're thinking about education related to assessment, exams, tools, and then repositories for our questions. I think the issue of assessment strategies across the continent, and for the different disciplines to establish the principles and types of assessments required. And if the conference supports the formation of this working group, then sort of the first order of business would be for them to identify their terms of reference. We also touched on the issue of EPAs and workplace-based assessments. And we weren't sure if this was going to be a regional approach. Obviously, we've done a lot of work on this within the CMSA, but we weren't clear if our sister colleges on the continent also want to go this route. So one needs to look at the extent of work and acceptance in other parts of Africa. But I think what's come out from the discussions today is that there's a general agreement that some type of in-course assessment needs to be done, and that's generally supported. But whether it takes the form of workplace-based assessment and EPAs as we see it, I think that still needs to be explored by the working group. Obviously, within the CMSA, we've had webinars, and that's something that also could be rolled out virtually across the continent. And then I think colleagues have spoken about the EPA workshop, which I think the different disciplines have been encouraged to attend. The other area that we touched on was the issue of single best answer questions and banks. And there was a feeling that there was, a lot of work has been done on undergraduate training, but there was a big need for us to establish SBA banks within postgraduate training. And that one could identify a few disciplines where one can start off with across the continent, setting up a structure and a repository. It was also felt that it was important to have training on the structuring of these questions, and also the issue of what proportion of new and old questions should be included in any paper also came up. Then there's this issue of standard setting as well as security of the banks. And we've kicked the can down the road again there to say that the working group should explore further the piloting of these banks. Another big issue that we discussed was the need for training of our trainers and assessors, and particularly in the area of assessment to start off with. And it was important that one looks at, from the previous slide, the structure of questions, but also that they are meaningful for the discipline and they're actually measuring what we need to. Examiner training needs to be standardized, and one should start off with onboarding of any new examiners. And I think one of our colleagues from one of the other colleges talked about the use of master trainers to train the trainers and to develop a pool of these. And then there was a view that training should be mandatory, scaling up over time. And I think there was support for formal certification. So a postgraduate certificate in learning and a postgraduate certificate in assessment, which would eventually lead to a diploma. I think the question about capacity and who would actually deliver this, whether it would be the colleges or the universities, that still needs to be discussed. And it was important that these courses are accessible to trainers across Africa. And then, another query was whether we also look at including the certification in KPAs and making it a requirement for promotion among specialists. And then, so the working group, if established, would then have to look into this process. I think that's my last slide. Thanks.
Thank you very much. I'll open the floor up for questions, but we have had a lot of nice discussions on this topic. And what I really like is that there's a proposal to establish a continent-wide task working group on this issue of education. But I'm sure there will be people who'd like to maybe reflect and ask of my two respondents here. But while we are doing that, I'm going to just comment on what you said while we are waiting for questions. But I would like the educational experts here, like Prof. Green Thompson, to come up on some of the issues. So one of the issues you raised was the issue of pass rates. So I think within the college, we do have a committee that's trying to monitor that. And I don't know what other people want to say about that, but some of the issues that are raised with that particular issue is the format of the exams that we need to look into that, you know, SBAs versus long questions. But maybe, Prof. Betch, you can comment on that if Lionel doesn't want to comment. So the comment was about pass rates. So initially, historically, in their college, they had low pass rates. And now he was proposing that they aim for higher pass rates. And I'm sharing that in our college, we've got that concern, especially for some of the surgical colleges. And I just wanted one of you guys, even Prof. Ngelwan, to share on the work we've done towards getting a good standard, robust exam that doesn't attract that kind of scrutiny.
I'll take one mic while the other one comes down to you. I mean, this is quite a controversial thing because you don't know what an ideal pass rate is. What is concerning is the number of people who are sending candidates to the exam expecting them to pass, and they're not passing, which means that they're establishing competence in the authentic workplace, and it's not translating into an exam performance. That's the problem. The other thing is that so one of the things that we have a lot at undergraduate level is that you should never have an exam where everybody fails. And the reality is that if you can defend your exam as being absolutely criterion referenced and every item adequately tested, then the pass rates become a different thing. So it's a very emotive thing that you must always have 50% or more people passing an exam. But it's a complicated conversation.
Maybe I can just add some comments. I think the essential issue is that competent people should pass an exam. So number one, you need to establish that people are competent, and that really needs to be done in the workplace in a formalized way. And I think until we've got that established, we really haven't got a baseline to work from or with. So that's an issue, and I think that is really one of the key mandates for establishing workplace-based assessment, so that we can bring competent people to an exam who've been signed off essentially, and the exam is a capstone event. The second issue is that one doesn't really want to look at pass rates for an exam either. On a fixed pass mark standard setting is a better option. And then if there are ongoing issues about competent people failing an exam, then there's a problem with the exam and it needs to be looked at. And we've done a huge amount of work, I think, in the last couple of years, looking at improving the quality of the examinations, and that's an important issue. Increasing the sampling is probably one of the most important issues in all of assessment practices. If you wanted to summarize 5,000 manuscripts in publication that are published, that's what the message would be: just get your sampling up. Sampling deals with a lot of the biases, it deals with examiner behavior, it deals with question error, it deals with examination design error. So I think if one has to tackle one key issue first, is that issue, and that is the one that we've chosen to focus on as a starting point. But then there are other issues like a variable pass mark to respond to the difficulty of the exam, and other issues around quality improvement, and particularly a double round of examination. I think at specialist level, it's a really important issue that the first round of examination is a process of defining that the candidate has got an adequate knowledge base. The second round of examination is an in-depth drilling to determine expertise. So double round or two-round examinations, composite assessment packages in specialist training, I think are really important issues. But fix the issues around, are you competent in the workplace? And then if there's still ongoing issues, have a look at the exam again. But we are working, I think, in South Africa, we're certainly working on establishing WBA and looking at improving the quality of the examinations, which is an ongoing process. Thank you.
Thank you very much for that. Okay, are there any other questions or reflections from the two speakers and from this section? Thank you.
I thank my colleagues for the presentation and provoking more comment and discussion on examinations. I gave a lecture to a group in the University of Rochester, sharing my experience with the West African College of Surgeons and our examination pass rate, when it used to be 30%, as Philip alluded to. Now, the question that came from the floor was, a number of questions came from the floor. First, who was funding the trainers? And there was also a question was, are the trainers, or who was funding the trainees? This question. Are the trainers being evaluated? And then, do we have a clear idea of what we're testing? These were questions. Now, but in the discussion that followed, the point that was made was that really, in the US, you cannot sustain a training program that churns out only a 30% pass rate, because the training will collapse, the program will collapse. It means that they are not being prepared well for the exam. So I think we will have to really be reflective as we talk about pass rates and all that. I think it's usually the light cannot always be pointing at the candidate, but also must point at us and see what is it that we are doing right or wrong. I think it's a big, broader conversation. We also have to look at the facilities where they are training. Do they have the resources to produce a kind of competent individual that we are aiming for? So it's a multifaceted issue, and we must really address all those in our conversation on leadership. Thank you.
Thank you very much, and those are very important comments. Okay, I think in the interest of time, I'm going to move to the second section, which was about reimagining leadership, letter to leaders and future leaders. So from that section, we've got two respondents and we've got two rapporteurs. So the two respondents are Prof. James Joey and Dr. Saad Larry. Please come forward. Thank you. Don't be far though, don't be far.
Thank you very much. It's a pleasure to be back after yesterday. Now, I think what I'll say has been said the whole morning, so don't expect anything new. We had a very interesting breakaway session. I'll also be very brief. And it was about leadership. The letter will come, and Professor Omaswa has even chapters and subtopics and subsections of the letter, but that will come. Now, it's about leadership. A good leader understands the led. And in fact, when we were having a breakaway session, one of the colleagues, I can't read his name, said he gets into class and his postgraduate students are so rebellious. No, we can't do this. We don't want to do this. And then a year or two later, they are towing the line. I think one of the things we agreed on is we need to understand the lead. And this came up during the discussions. Sitting with that resident or the registrar for hours, days, we would probably understand where they're coming from. And that would help them change. One of the other things is listening to the youth. That also came up in our discussions. And some of us said we wish we were listened to. That was to answer Flavia's question. We wish we were listened to when we were still raw students. Our own mind is very easy to cultivate. So if you understood the lead and you listened to them, got what they're saying, and guided them, you would then be in a very good position to nurture them into good leaders. Because, you see, decision-making, whether it's by the bedside, whether you're treating meningitis or pneumonia or whatever the case may be, decision-making has several facets. It's not just the knowledge. The process of making that decision of this is interstitial lung disease has a lot of input. Is your knowledge, is experiential learning, and so on. So when we listen to the young chaps, to what they're saying, we use that background knowledge we have to give them the appropriate guideline, the appropriate responses, and they become leaders. They become good leaders eventually. Historically, medicine has been an apprenticeship. If you read history, there were no exams, and I agree with Prof. There were no exams those days. But I came to the ward and I saw what Prof. Maswa did. And historically, there's a lot of, my teacher used to say this, my teacher used to respond in this fashion. So as leaders, we have to show by example. We have our knowledge, we have our decision-making process, we learn through the times, experience hits us, experience builds us, and we eventually nurture those who are following us. One of the other things is good leaders inspire, and inspiration is very important. If I don't inspire you as a leader, then I wasn't a leader. I was probably just in the front row. I wasn't a leader. And the other things that we also discussed, and I think I passionately believe in, is mentorship. And after mentorship, there should be succession. The topic is about wellness. It's very disheartening to see a leader who is a very prominent cardiologist at the age of 60, still doing cuts at 3 a.m. That's not leadership. And that is what your juniors will feel. If you mentored them and got into a proper succession, they will do that when they come. So I think we need to have these mentorship programs. We need to have good succession. And it leads to wellness, because I think the whole concept here is about wellness. Open-mindedness, which again comes to listening to the people you're working with, whether they're juniors or your peers or even your seniors. And creativity also builds good leadership. Now, like I said earlier on, that medicine is an apprenticeship, and people see what we do. We are observed. We are being observed, whether in the workplace area, whether outside the workplace areas. So we need to have, and there's the issue of you have to be good as a person. You have to be good. And what this means goes beyond the scope of the discussion. But if a leader is good, whatever they do will be followed in succession, because we are being watched. And like I said, we are being watched in all places. So if what I do is right, even without talking, I'm actually leading. And I get a very good succession. Now, finally, I said I would be brief. Finally, there was the issue of leadership training, the issue of teaching, and it had been said there are several curricula that have this, and one would also mention that in our curriculum as EXACO, in the 4th year of training, we have the senior trainees take part in leadership. And this is an ongoing process. So during the ward rounds, I stand back and I watch them conduct the ward rounds. At the end of the day, I give them a feedback. During case-based discussions, they lead. So this is how we inculcate leadership and teaching in the course of the curriculum development. And we hope over time this will improve, and we hope over time the trainees that we are going to get would be holistic rather than those who are cognitively sharp. But we need good professionalism, we need good ethics. So there's a lot about leadership. Actually, I'm in this group serendipitously. I wasn't meant to be here. I was meant to be in the exams group, which I enjoy, but that is what it is. We had a good discussion. Thanks.
That was great, and I like that you added a few other attributes to what we heard about earlier, especially mentorship and apprenticeship, leadership. I'm going to allow Prof. It's Dr. Larine. Sorry. He's from Stellenbosch. He's the head of emergency medicine.
No, not the head. I just. Hi, good afternoon. My name is Saad, and I'm the president of the College of Emergency Medicine. I work at Stellenbosch University, and I run the medical emergencies department at Tygerberg. Right. Will they load the slides? I'll start so long while they're going to load the slides. So I'm going to try and consolidate the themes into what we do in emergency medicine and the lessons that we've learned and where we're going. And I think there's a lot of the themes in this conference that will definitely overlap. Now, the emergency environment is a typical VUCA environment, right? It's volatile, uncertain, complex, ambiguous, there's resource limitations. I worked for 10 years at Kailicha Hospital, and I ran the emergency department there. And as you can see, this is just the resuscitation area. There's 1, 2, 3, 4, 5, 6, 7, 8, 9 patients, 1 nurse, and 1 doctor. Right? In this environment, you've got to provide patient care, you've got to teach, you've got to make sure that things happen. Right? Now, another thing about that is that I was just one consultant. I can't be there all the time. I've got to teach. I've got to make sure that patients can still get care when I'm not there. So the person who's doing that resuscitative thoracotomy on an 11-year-old who was stabbed is Nuran. And she's now an emergency physician. And I asked her, oh, so Nuran, why did you decide to do EM? She says, no. The one day when I was a 4th-year medical student, you told me to take a patient to CT and bag the patient, and this was going to be the most important thing I was ever going to do in my whole life. And she says that she never forgot it. And that feeling and that is why she did it, and why she continues to do it. Just an aside, the other people you see in that picture are from Ivy League schools in the US. So every single Ivy League school in the US has come to train by us at Kailicha. And that's something that we need to take away for us in Africa, is that we do have the skill set. Now imagine somebody who's at Kailicha, trained at UCT and Stellenbosch, is teaching Ivy League people in the US. Right? And that's happening everywhere throughout Africa. Right? We have to believe that what we have is valuable. So the burden of disease is not only that, but it's also kids, right? And that's why when we lead for examinations, it becomes very important to be very contextually driven. What is our burden of disease? What are we examining people on? Is it relevant is it what we expect people to do? Is it what we want them to do? Right? So what does an emergency physician do daily? Right? And basically we have followed this philosophy in our examinations. The training and assessing healthcare professionals boils down to one simple question. Can they be trusted to provide safe, effective, and efficient healthcare? And we form that as the basis of the introductory email that we send out to the examiners. That when you set a question, can you please ask yourself this before you set it? Right, so we've needed to undergo a transformation. We never had a curriculum. We had a syllabus. We had a list of topics on a textbook. There was no learning outcomes. Because everything was driven with the best of intentions, and we all stand on the shoulders of giants, but it was clinicians who were patient experts, right? So we've had to learn, and we've had to undergo a transformation, undergo what is called a metamorphosis. In the end, you do create something much more beautiful. So my question is, how do we make a difference as a leader? And what I look at is that somebody somewhere is up to something. Somebody's a busybody. Somebody's got something to say. Right? And we all have a future that we want to envision. So all that I do, because I don't have all the skill sets, so I just put all of them together. those who believe in that same future, we engage, and in the end, they must deliver. Right? So what we did about a month ago, we got those people who are busybodies, who were just busy popping emails and WhatsApp, and said, yeah, come, fly down, we're going to put you in a hotel, we're going to pay, and let's do stuff. Right? So we got people from all the universities, and we got also other doctors from the Young Specialist Forum to come as well. And we started renewing our curriculum. Right? And part of that was a massive partner engagement. Right? And part of this partner engagement, people had to go back to their places and ask them, what is an emergency physician? What do you expect them to know? What do you expect them to do? Right? What is the identity? And people came up with drawings. And as you can see, right, these drawings, I really love them, right? There's a whole lot of values in there besides of the skill sets. I don't know if you can see the one with the crown, it's got a heart there in the middle. And there's somebody who's a listener, kindness, and compassionate. So this is from the partner engagement, right? So this is from nursing, management, from everybody else. This is listening to different voices. And in the end, we came up with something very African, which is the baobab tree, right? And in this baobab tree, and you can see over there, there's well-being and self-development there besides the medical expert. And we grounded this in social accountability. But you'll see the last two, oh my word, what did I do there? Well-being and self-development. And that's before even this conference. So you can see already those ideas and that vision is there. We just got to put the people together and get it down on paper and just get them to believe in, and just get the people to believe in it. Where are we going, right? So we decided, listen, you can't be failing the final exam and that's it. What happened during the 4 years? What happened, right? And we said, okay, listen, we got to try and do something. And we said, okay, listen, let's have an annualized standardized performance exam, all 4 universities every year, 12 to 15 OSCEs at the exit level standard that we expect you to be. Even if you're first year, you have to do it at the exit level standard. I said, let's try it and let's see where that takes us, right? And we'll fly people around to do externals, but we'll do it every year, right? And we came up with something like this, right? Where, look, this is a bit granular and we still need to work on it, but in here, we're holding the trainers accountable and the students, where there's a portfolio of evidence, mid-block and end-block assessments. We're going to incorporate shift reports, 360 assessments, all of those things, right? And we're going to give it some marks because that's what the partners wanted. They say, no, fine, you can give us feedback, but we want that feedback to count. And they saying it. So we're going to try it and see. COVID-19 was a big problem. And COVID-19 forced us to adapt and innovate, right? Life throws you a lemon, you make lemonade, right? We had to, our questions were 25 marks, 4 questions. I mean, that doesn't make any sense, right? So we had to devise standard SPA MCQs. We had to do this within about 6 months under the guidance of the college, and we managed to make it happen. It happened, right? We had to do it. It really happened. We had patient-based assessments. We had to move that. So we moved that to what's called case-based assessments, where we tested clinical reasoning. In the Vivas, we retested issues around leadership management and also communication, and we put forward a critical appraisal station. Right? So we've tried stuff and we've carried on with it. The big challenge we always had was the examiner mindset, right? And this comes in with the examiners always wanted to be stern, to be very, very sort of, you're not allowed to make any gestures. At the start of every exam, we remind people that kindness is always in fashion. Never goes out of fashion, even in exams. And it's not illegal to smile. I don't know where that came about, that you cannot smile in exams, right? Right? So I said, no, you will smile, and all the examiners will smile. So we standardize the smile. Right? So I said, it's not illegal to smile. Why are we doing that stuff? Okay. How did we get the buy-in? The buy-in, we moved from the concept of change management to what we call change leadership, where we articulated the vision of the future, we mobilized the resources that we needed, and we thank the college for that, right? And we put an engine on the change process, right? Okay, so we moved from the management to the leadership part of it. The DPEC, so the diploma exam, I just want to spend a few minutes on this. I know I'm a little bit over time, all right? So basically, this is our non-specialist exam of a junior doctors that is primarily knowledge-based. And we started in 1988 with 2 candidates. In 2012, it was 21. We're sitting now at 153 candidates, right? And these candidates come from Ireland, Libya, Kenya, Botswana, and Namibia, including South Africa, right? So we've expanded it throughout. Right, so this has been a great success story. Lastly, on the leadership aspect, you know, every kid needs a champion. Someone who's going to believe in them and someone who knows their worth. The other important thing is that we have to show our own vulnerability. I failed my primary exam, and I'm sure many in this room failed some exam at some point, right? We've got to talk to them about the finer points. We've got to tell them it's okay to be imperfect. It's okay to fail. But I'm there to help you to get up and to fight again. All right. I can go back. Oh, my word. Sorry, I don't know what's going on here. Yeah, so I believe that the cognitive apprenticeship from honesty is massively, massively huge. Often people see us and they say, no, it's this big president that's coming along here. But then they say, this president who smiles and who talks and, who has my back. I think that's okay as well. Everybody does a number 2. All right. And I think people want to know that if there's trouble, you're going to help them and you're going to clean up after them. We've got this one registrar. Now, I'm at Stellenbosch. Now, she's failed the exam 4 times now. Right? So she's now trying to get help. Now she comes to another university for help. No problem. You can access anything you want to. And that's the beauty about collaboration, that we don't necessarily have to have boundaries. I think there's, you belong to University X and you must, only sit with University X. I don't think that's the right way of doing things. The big thing we re-emphasize is that of resourcefulness, where failure is okay and the line to success is not straight. I think that's a massive important part of leadership that also was really emphasized today. And lastly, I think for us in this room, one of the important things, just my take home, is that we have to plant the seed under which the shade of the tree we may not sit. Right? So I think we mustn't lose hope, but we have to start somewhere. Okay, thank you.
Okay, thank you very much for sharing those authentic insights, especially the toilet paper. Yeah. Okay, so now I'll call on Prof. Marisa Foster, who's the president of the College of Nuclear Physicians. That is correct? It looks like I got the wrong brief for everyone. That she's the rapporteur for the group, and hopefully you'll get into the letter to future leaders and leaders. Thank you.
Thanks, Jay. Yes, I am indeed a nuclear medicine physician. Now, there's a specialty you didn't hear all this week, but watch this space, please. Okay, so I'm giving this feedback on behalf of the group and with my colleague, Professor Naidu, who unfortunately had to leave. So I always start with my conflict of interest, which is that I'm 100% introvert. So my conflict of interest is I'd rather be sitting there, but I speak about things that I feel passionate about, and that's why I agreed. Okay, let me Okay, so just to give some structure to the feedback, I'll outline some of the keywords that I heard even during the plenaries before the breakaways. Then I'll mention some of the discussion points, and we'll get to the letter saying, "Dear Leader." So some of the keywords that you can see there are not only keywords, but they also seem to be characteristics or core values of a good leader. So if you look at that, there is flexibility, creativity, integrity. We heard fit for purpose a lot. We heard innovation, collaboration, a visionary, and you have to have courage. Okay, and resilience. Of course, transparency. We spoke about sorry, I know I'm supposed to be looking there, but we spoke about the importance of ethics and persuasion, discussion with people that you are leading, and not just making top-down decisions. We mentioned VUCA, and that was nicely explained by our emergency physician. Also the need to predict and plan and perform. And then the importance of adaptability, that came up again and again, and the issue of emotional intelligence. Also that you need to be a communicator, and stressing that we need those skills of writing and speaking. So even before we went to the breakaway rooms, we had this discussion about keeping in touch with the community that you're from, just remembering where you are from and who the patient population is that you're serving, and how we need changes to the current curricula. We also emphasize that there is currently a lack of teaching for leadership, for financial management, and in terms of communication skills. That you have to lead yourself, that you have to have certain characteristics and self-insight, EQ, and that all of these things take time. Also, not to forget about the influence of AI technology and the costs associated therewith. So then we went to the breakaway room, and it became more, we elaborated on those points, and we started off with a discussion on how we should move away from the vertical leadership to a more horizontal leadership. And it was called an osmotic relationship. So a relationship that benefits both parties and goes horizontally. And so in that way, you share your attitudes and your experiences and your traits. Also to crucially remember your purpose, because that's what gives you vision. Our president pointed out that you need a sound moral and ethical framework. We need to listen to others. Professor Ramlal highlighted that there's not only the 4 leadership styles, but also the servant leadership that we need to keep in mind. Then the importance of the mentorship and leadership courses, the idea of not just leading, but also being led, and knowing how to deal with that. And it was coined almost a 360 leadership in one of the later discussions. So how to help others develop their full potential and being a mentor, but also not becoming lonely at the top, when you need to have some support system and advisors who can help you when you have those doubts and when you are alone making big decisions. We also emphasize that mentorship and leadership is not a once-off, but a dynamic process, and that it starts ideally even from undergraduate level. So then just to highlight again the point earlier that I made earlier about the doctor having to come from the community that you serve, and that to remember that central to all of this is your patient. And you can't possibly be a leader in terms of research, teaching, and patient care if you forget that aspect. So to focus on your patient-centered care, and then to have a clear vision for your discipline before you start your plan. So this also hinges on teamwork and communication, which we've highlighted in many aspects. So then that brings us also to the caring leader and having a social responsibility. So now we say, dear leader, and we say, firstly, remember your purpose, because that gives you your clear vision. And start with the end in mind. So once you have your vision, now you need to develop those skills that you need in order to achieve your vision. And you create your, what was called an own ecosystem. And so get involved in decision making. Don't just sit back at every level, really. So get involved in governance. So we tend to be disconnected and not get ourselves involved in these discussions where budgets are discussed and all sorts of other aspects. So get involved. Demonstrate cost effectiveness. We spoke about it more yesterday, but to be able to show that something is cost effective, sometimes you need to show someone it's not just the initial cost, but what you achieve with that. The effectiveness part, I think we leave out very, very often. And those skills we need. So, and then importantly, develop others and take them with you. So that message of lift as you rise, which is such a nice message from Bongani Mayosi and many others. So develop others. And then have advisors and support system and be innovative, flexible, and collaborate. And then don't wait for that position to be a leader, as we said. There are also some other don'ts, really the opposites of those that I've mentioned there. But if you're selfish, if you become isolated and inflexible, those are the things to avoid. And say yes to opportunities outside of your comfort zone, like this one. And then, so where do we post that letter to now? So before I get to that, I just wanted to acknowledge our elders, because we need to end off with that, acknowledging our elders who said that leadership is a state of mind. You have to be an agent of change, and you have to lead others in a sustainable way and have that succession planning. And you also mentioned the 360 leadership. And so we posed this letter firstly to ourselves, and then we needed some outputs from this discussion. And really there was a suggestion to call it Future Africa Commitment and have it in the form of a document, a pledge, or in the Lancet, a declaration, or a report, which our CEO pointed out we, in any case, doing. Okay, and then love those you lead. Thank you so much.
Sorry. Thank you very much, Prof. Foster. I'll allow only one question because we don't have time. It's on.
It is on. Oh, of course it is on. Yeah. Maybe not a question, but I can put it as a question. Where is the interface between this medical specialist leadership and politics or politicians? I think there are many things we can't achieve unless we have thought about that.
Yeah. Thank you for that question. I'll put it straight to the panel.
Yeah, usually when you're told there's only one question, it's usually a crazy one. Now, I think it came up in one of the discussions, because I think as doctors, I think we are, you said you're introverts. We are very introverted. And we are always left out by legislation. If you look at most countries, the lawyers get what they want because they're in parliament, they're in decision-making places, and so on and so forth. So this interface ideally should be us. I think we have to learn to come out and be our own agent of change, be our own advocates, so that if we're in positions of decision-making, we should be able to get this in place. It hasn't happened, it's probably beginning to happen, but you find even in political space, when you have doctors who get into the political space, they totally change. And they said, is this a chap we were in class with? Because of the kind of, in brief, I think we have to start to learn to defend ourselves. And we can only do that when we are in places of decision-making, places of governance, in politics, in church, and so on and so forth.
I think it starts locally in your own hospital. So I have to frequently motivate for new traces and new equipment and things. And once you start speaking on a management level in the hospital, those people that are then able to take the discussions further. So you have to engage first in your hospital and ask those people to take it further. But if you're even not involved in that very local discussion, there's no way you're going to get involved.
Thank you for that.
I have a very non-eloquent answer. I just nag. I just nag. There's this one politician who comes to the same gym as me. I nag every single day on his. And eventually, we did get what we want. So it's persistence and persistence and persistence. You know, we start off with a very small circle, right? And that's our circle of control. But as we get really, really good within our own circle, that circle of control becomes bigger and bigger and bigger, and that extends into a circle of influence. You know, so I got hold of him at the gym, and I said, "Listen, come visit." I said, "Come, I'll take you for breakfast." And we went, and we got what we wanted. Right? But it's just that forging that partnerships, going across those boundaries, and just persisting. The intention is good, right? It's for the greater good. So just make it happen.
Thank you very much. I think with that, we'll end the session. And just to recap, collaboration is a common theme on both sides, especially with the medical education, where we are talking about a Pan-African task team. I like the word Pan-African. So there will be a session where we'll recap everything. But thank you very much for being an obliging audience. And I'll hand over to the next speakers now. Thank you.
So, Prof. Nkaka, since some of the speakers are leaving early, if we could please do a photo of this plenary now. The photo for all the speakers, including my dear friend, Prof. Marisa. I do as instructed. So the chairs as well, Prof. Ngalwane and Prof. Gopalan. Thank you very much, Siyabonga. So for the colleagues who are coming from other countries, you at least have to know 2 words. So the one is Siyabonga, which means thank you. So colleagues, it gives me great pleasure to welcome the young specialists. I think it's a new addition that we've added as a unique feature of IMELF Africa. And so I am going to call upon the chair of the Young Specialist Committee, Dr. Trevor Mnguni, to come and chair this particular session. Over to you, Dr. Mnguni. And since he's taking a long time to come up, he sent me an email while he was still specializing and said, I have a couple of things to discuss. And it was during lockdown. And then we we had this virtual meeting. And then he said to me, I didn't think that I'd receive such kindness from the colleges of medicine of South Africa. And I said, since you have so many issues, would you like to be the change agent? And here he is today, Dr. Mnguni.
Good afternoon, colleagues. afternoon to the Congress Chair, to our President, Johan Fagan, to all esteemed colleagues from all over Africa. I mean, it's a very, very humbling experience to be here from that first conversation and that first email to find myself here. And I kind of feel like my pediatric surgeon colleague there, and be careful about the crocodile, before you cross the river. So this is the area I found myself. So, but yeah, I think, we obviously, our session has now come in. I've had colleagues pull me over and say, look, just please make sure we make it for our shuttle. So we actually have come up with a very informative session in terms of where I actually want to get all my panelists down here. They'll introduce themselves. And we've also got 2 slides where we're going to discuss issues regarding to the program and then obviously coming up with solutions. So I think what I'll do, I'd like to let my panelists come down before we move on to the first slide. And as they're coming down, I just also want to say we one person short. Dr. Ngobile Tango had a family emergency, so she unfortunately wasn't able to join us. But yeah, Lionel, again, to your point, I still do have a female predominant panel. So yeah, so thanks for that. Can we just move on to the first slide? So there's a lot of challenges that we've discussed in terms of that are affecting the young specialists. And they range from various sectors, which cuts across all disciplines. Some obviously pre-existing that have always been there, and then there are some that have been brought on by the COVID pandemic. And essentially, what my panelists are going to do is that they're going to just essentially speak onto some of these points, mainly from a personal experience, and then as we draft our way as we move forward. So I think the first part that has come across and cut across quite a lot in essentially almost all the talks has been the issue of mentorship. And I have no one more other esteemed in our group than Mike, who's going to be tackling that. So I'll let Mike just tackle that. If I can get just 2 roving mics, please. I'd like the guys, can I just get a mic so they can just talk while in their seats? Anybody? You got one. Cool. Thanks. You can go ahead.
So good afternoon, everyone. My name is Mike Mwachiro. I am from Kenya, and I'm also with COSEXA, current chair of the Education Scientific and Research Committee. And I also run the general surgery training program back home. So mentorship is something that is really close to my heart. And I will start by saying, during the COVID lockdown, I think a lot was happening, because for me, during that lockdown, I put down my thoughts on mentorship in a book, which is actually available. And that book was a reflection of my medical school experiences, because I was assigned a mentor. And when I went to see him, he asked me, "Who are you? And why are you here?" And I was very shocked. So I went back to the dean and I said, "You gave me a defective mentor." so I was assigned to a new mentor. And that began a journey, because it's been 2 decades now. We are still friends. I know him well. He's a family friend. He's been a godfather to my children. And so I can honestly say you can have both sides. You can see both sides of the coin. If you talk about stories, and in Africa, you learn from your elders. So for us, it's been good to sit here and to listen to some of the stories from the past and what has been done and the achievements. The second thing I will say is, with mentorship comes sponsorship. And that is creating the opportunities. For our residents now, when they have opportunities to go for training and for conferences, we make it happen. I think one of the questions for medical education is, how do we, I think it's hand-holding. Like somebody talked about it just now. So I was in the education committee for almost 5 years, and most of the things I've done was modeled from watching the previous chair, Russ White. And we spent so much time, but that by the time I was taking over, it didn't feel like a daunting challenge, because I'd seen him do it. The other thing I'll talk about is the vulnerabilities. So I'm a surgeon, and I remember we were doing an oesophageectomy, and we got into serious bleeding. And I remember the lead surgeon saying, "Mike, this was my mistake. I have never forgotten," because he said, "I will do the M&M." When you're a resident, you fear standing in front and explaining what went wrong. He took us through that M&M on that day. And for me, that was such a powerful example of modeling what to do and how to deal with failures. Now, the last thing I'll talk about when it comes to mentorship is how do we, especially in the medical education field, so our trainees learn a lot from us. You know, when you tell them, be on time, come to the lectures, those unspoken things that are modeled is what many people pick up, and they actually do that. And I used to say, no, I will never do this. And now I realize many of the things I do now is because of what I saw my trainers doing and my professors doing. So we become who we see. I think it's a very powerful thing, and I really commend the organizers of this event for bringing such a diverse array and life stories. We've seen from the various colleges that we've been interacting with how they've handled various challenges. And through it all, you know, yesterday I was talking to Prof. Rana, and we were talking about burnout. It's one of my pet subjects, and he told me one thing. You know, as a surgeon, you get burnt out if you have bad outcomes. And I said, that's actually true. If you have good outcomes, you're motivated to do more and more and more and more. So the more success you have, the more feeling of, you know, being good that comes. So I think it's up to us to decide as an African continent how we want this mentorship and sponsorship space to look like for the coming generations. And I think, what are we leaving for them to latch on? So I'll stop there to allow my colleagues to move to the next discussion.
Hi, everybody. My name is Sandra Maepa. I am a former UP undergraduate. I'm quite happy to be here after so many years, because I left and that was it. And I was at Wits the rest of the time. And my part is to highlight what we've learned and why the Young Specialist Committee was even created was because of the challenges that we were facing with registrar experience and trying to get them on board into a new changing colleges of medicine, which tries to make a holistic registrar, which is what we aim for. I think one of the things is that there are inequalities in registrar training, and that's across institutions. That's also across every hospital, everywhere. And the reason for that is because of how our structure of the health department and how we hire registrars. It speaks to a lot of the deficiencies in our systems. And I just want to highlight a few of the things. That it speaks to lack of exposure to advanced technology, lack of resources. Consultant numbers are low, and therefore the quality and the availability of supervision gets compromised. And what we're trying to do is not make the student in training become so much of a servant that in 4 years' time that we actually don't have a whole registrar who is now a specialist. Firstly, to speak to this potential registrar, you must start at the beginning. We assume coming into the program that all registrars had equal opportunity. They come with the equal skill set, equal opportunities to be the best that they can be. But the truth of the matter is that that's not true. What you come across as on an interview, we know on a consultancy level that you actually start to see gaps in knowledge and gaps in skills. But the point of all of this and why we're all here is to promote a better way of teaching and have checkpoints in place that actually identify registrars that are in trouble, not at their exit exam. We don't want students getting to the 4th year and they're about to write exams, and then we find lacking that these students have actually not been in one, a mentored environment, supportive environment, access to technology and education and knowledge. There has to be a fine balance between service and also formal academic teaching. So mandatory supervision is key. It's mandatory. It's not, I've got a clinic and another clinic and I can't do it. Mandatory. And work-based, workplace assessments, you know, very timelessly and placed assessments of registrars from their 1st year right up to their 4th year is important. And I'm glad that we're having conversations around that. Because one of the things that many of us, and I don't want to make us sound old, we're quite young, how we trained was, good luck to you, you made it to the 4th year and you set enough time to have studied enough and you made it, well done. But the truth is, we needed formal academic teaching. It isn't, there's a very strong responsibility from a registrar point of view, but there's an equally just as strong responsibility from the trainers that have to make sure that at the end of this we have a successful candidate. I want to also just speak about the rising burnout, fatigue, depression, and anxiety that is on the rise with registrars, where our patient profiles are not getting less, meaning that our patient numbers are increasing steadily. And it means that you have the same few numbers of registrars that are in these settings, but they're exposed to just as much of a very challenging circumstances. If we are to let things be, and then we end up with students that end up repeating exams, final exams, fourth time, third time, we actually are a breeding ground for anxiety and depression. And I think those workplace assessments, mentorship, all of that comes together to try and reduce the circumstances. I'm going to let my colleague Inga just speak about toxicity in the work environment, toxic environments that we work in, and how to make things better. But one thing for sure is that we are in an age where we have no excuse, and COVID taught us this, that we have no excuse on standardizing, equalizing the playing field with knowledge and education. Doesn't matter whether you're from any country, whether you're from WUSU, whether you're from UCT, the knowledge should be out there and just as accessible to everybody, so that at that exit exam, we are all on equal footing in some ways, and we can have more pass rates or better pass rates that we speak of. I was also tasked to speak about politics and economics and how they impact everything. The political climate in Africa and South Africa as a whole is one that is unpredictable. We never know whether we're coming or going, whether Eskom is going to give us electricity. We never know what's going to happen. But one thing for sure is that it has come to be that we can no longer be passive, and we need to be the people that are engaging in ministries where we talk to what is needed. We, the service providers, but more importantly, the people that we serve, which is our community. These impact us with regards to the number of consultancy posts, the number of registrar posts that are available, and the type of service that we provide. If we are to be world-class and ever so much being progressive, then we need to make sure that we have those facilities in place, resources in place, irrespective of the number of patients that we see, and we should be seeing improved outcomes. But as we stand now, we have been on the receiving end of what goes on politically and economically. We can no longer keep quiet. My solution is that we are the people that need to get up, and we are the ones that need to engage with the ministry, National Department of Health, to say, this is the reality, and this is not gonna be what we accept. And unfortunately, it does mean you do it once, twice, 3 times, 1,000 times. But I think the persistence, I think someone spoke about just persevering through that and repeating the message to that and engaging with the Department of Health is what we need. I think I'm gonna stop there.
Thank you so much, and good afternoon, everybody. I'm Inga Kleinhans, and I'm currently a registrar in training in public health medicine. And so I'm also part of one of the subcommittees of the college in terms of membership and career pathing, and also a communications director for Women in Global Health South Africa. And I've been asked by our chair to communicate a few important elements of the registrar experience when it comes to workplace toxicity, as well as what it's like to be a female in training. So acknowledging that with time, our profession has slowly become more inclusive, acknowledging that there's an increase in both undergraduate as well as postgraduate intake of female trainees, we still face gender-related challenges affecting both the well-being, opportunities, growth and development, as well as contributions that we can offer to the fraternity. And so one of the most significant challenges that we face coming from a female perspective in the arena of medicine would be that it's difficult to find an opportunity to secure a training post. We know that with time this has improved, but also to make the choice in balancing a career versus having a family. And so with a fraternity that has had a past culture of being inflexible, and some of the resolutions coming from this conference aiming to go towards transformation and changing that and being adaptable, we know that there are a few elements in place that still makes it inflexible for female trainees in terms of continuing their training and the impact that things like maternity leave would have on that, as well as the support that's offered to those who are already in caring responsibility roles. Additionally, I'd like to just highlight that there is an impact on registrar trainees, especially females more so, but we aren't incognizant that males go through the same. And that is the vulnerability to sexual abuse and harassment in the workplace. And so because of the impact of this on especially the female registrars, I'd like to sensitize the audience to this and the seriousness of the matter so that this is kept in mind when we do go about our transformation into what we'd like to say for the dear and the future leaders. Again, the training environment in itself has been over time inflexible in the terms that we are trained to endure and continue facing challenges head on. However, if we look at the recent decades, we know this comes at a cost of our emotional well-being and our health. And so we've noticed that in the past decade, there's been an increase in registrar and fellow suicides, and this requires urgent attention. So lastly, I'd like to allude to the fact that workplace toxicity contributes towards burnout, and we can't just focus on this in young specialists, but this needs to be cultivated not only from an undergraduate perspective, but also in the registrar training from the get-go. Can't only focus on it when a new young specialist is born. And so all these challenges call for transformation in leadership with solutions that impact registrars from the get-go, and this can include some in terms of policies that change to lead towards gender transformative policies, and these include policies that would be inclusive, diverse, and decrease the gender bias across the playing field, and have equal opportunity for mentorship as well. And then lastly, I'd like to just allude to the fact that we can cultivate a culture of leading with humanity within our fraternity. And hopefully by doing so, we can create a profession that's not only inclusive, equitable, and supportive of all its members, but leads to sustainable and resiliency in our health workforce, both locally and in the African continent and globally. Thank you so much.
Oh, thanks very much. I think, the issue of COVID has been massive. But I mean, I think more so on the trainees and the young specialists. I mean, I think if you're in your second year of training when the pandemic hit, and then 2 years later, you are sitting your final exams, and especially with, disciplines where it's a lot of interventions that are needed, you've lost out on a lot of crucial time. I think as a physician, those are also quite extensive clinical years that you lose out. And that's been massive, because we are actually seeing guys who are really now coming out to the open, who are essentially out there, who are not really, up to the standard in terms of the training, that the skills they could have acquired. And it's not due to any, of the issues that's related to them. It's just how, things have turned out. And I think that's something that we need to highlight, because, I mean, these are our colleagues who are, some of them have ended up in the private sector, in the private practice. And the question of, comes back in terms of, how do we actually, reintegrate them back? And I think as a job for us as young specialists is try to get people back in terms of, in some sort of a training, sort of as things pick up again, in coming back to, doing odd cases again, and just making sure that, we also just curtail and make sure that we don't lose that opportunity for them to gain the skills. And then the other big issue that I think, is crucial to us moving forward, and I see we haven't really touched on during these past 2 days, which was laid essentially bare by the COVID pandemic, is the leadership void in nursing. That always has been there throughout, but I mean, I think COVID's just accelerated that. We heard the other day that, you may have the surgeon, but if you don't have the anaesthetist, you can't do the operation. I'd like to take the step further, that you can have the surgeon, you can have the anaesthetist, but if you don't have the nurses to, deliver that post-op care, or where you're going to get your patients to be monitored, you equally have the same problem. And I think far too much we, as physicians, as clinicians, we don't take our nurses with us in terms of when we have these discussions. And I think, it would be wise to try and include them in these forums, just the leadership aspect from the aspect, whether we get the South African Nursing Council on board when we have these discussions, so that they can actually be part of the solutions in terms of how we do when we're moving forward, because that is a massive impact. And we do know essentially when it came to the COVID pandemic, most places couldn't actually run more ICU beds, not because there wasn't staff available or human resources, just not enough nurses to run those beds. So I think that's an important aspect, and that we sort of, I see with, and as a junior doctor, that we sort of, you would go on and grumble on as if, we cannot actually be part. And it's always, us and them. And I think we really, really need to get our nursing colleges and our nursing colleagues into these spaces. And I think it's an important aspect as we move forward. And then the big issue, that young specialists are also going to face are the other issues of transitioning into private practice. We've spoke about the issues of austerity measures. We heard yesterday that the fiscal is going to be 8 billion short in the next financial year. So things are not really looking good. So we're going to get a lot of posts that are going to be frozen. And then the question becomes how do we actually train people or help them to, our colleagues that have to start the private practice, how do you get them up and ready to do such a thing? And I think it's something that, we basically really have to, take that on. And I think that will serve two purposes. And then the first purpose is allow the guys transition to go into private practice, but then it also gives them linkage back to us when they need that sort of care. So I really do think that those are quite important challenges that we've sort of identified. Some of them, as I said, are quite repetition in terms of what has happened over the past 2 days. And what I'm going to do now is just, we've also come up with a few solutions where we think that we could, be impactful. So I'm going to please ask the guys just to move on to the next slide. And then basically here, what we really want to talk about is the issues. Now, what are the possible solutions to all these problems? And how can we actually make sure that, we're able to, and to link them? So I'll pass on again to my chair, to my panelist, to please talk about the issue of mentorship.
Yeah, thank you, Chair. So I will start off. So I think on the mentorship front, a lot has been said already across the various sessions that we've had in the last 2 days. But I think just looking specifically on the young specialists, there is need to consolidate. So for example, in COSEXA, we have such a large number of graduates every year who are coming out there. And some of them that I've met ask, what happens after you finish? They've been practicing for a few years, and now they're in that, I call it limbo, when you're deciding what next you want to do with your. It's like a midlife crisis for specialists. You are out of training, but you haven't subspecialized, so you're waiting. And I think we can tap into this, and some of the opportunities include plugging them into committees, into forums where they can, if you have, helping with exam writing, like what Works has been doing, having them contribute towards running the organization and actually preparing them for these opportunities. The other thing is to think about the question of, we can actually formally think about helping people who are about to finish transition to independent practice. All of us remember the first few years when you have to decide, am I going to focus on clinical practice? Am I going to do admin? Am I going to do research? In Africa, sometimes there's no protected time. I think that's a common problem. In Kenya, if you go into research, you might not have something to eat. Some of my classmates ask me, Mike, why do you do research? How do you survive? You might as well do private practice and make money. So it's one of the solutions would be to have programs to help transition graduating specialists, whether it's in surgery, nursing, midwifery, obstetric, gynecology, to think about those questions. How do I navigate a job interview? Is there a specialist who can help me with looking at this contract and making sure it's a good contract? So there are those practical questions about starting your practice as a young specialist, which many of us had to navigate on our own if you didn't have someone that you could talk to. And then finally, I think we've talked about the leadership opportunities. I was going to talk about the Albert Luthuli Institute because there's a great yearning for leadership training and medical education training. And I think I'll reiterate this again and again. There was talk about the postgraduate certificates and diplomas. If we can see how to plug in more and more from the continent into these initiatives, I think that would be one good takeaway from this. Thank you.
So my fear with the word mentorship has always been the fact that it looks good on paper. You can write it down, strategize it, but implementing it on the ground is really a leadership-driven process, if I can put it that way. It has to be a physical thing. It has to be done, actually assign this person to that person. And I find that sometimes what is envisioned as a good idea for mentorship doesn't actually practically happen. I'll make an example. I think when I was a junior consultant at Chris Baragwanath, what used to work very nicely is that we would just attach ourselves as young consultants to any registrars that were preparing themselves for exams. And this was purely done because we knew what we experienced when we were senior registrars, not having an idea whether is Kuma better than Royal College of Physician notes. We had no idea. And giving them that advice on, this is what we did as a group. We did what we call parallel learning. Parallel learning meaning image, knowledge, webinars, all of it, one topic, but you have different medias of how you can study. And sometimes it works for people who can retain, memory of subjects. And the whole idea is, it worked because we wanted to do it. But if it is to be implemented, and it should be mandatory, then that's a leadership-driven process. It shouldn't be just said in these rooms, but practically on the ground, it's not happening as we want it to be. So that's one of my many concerns about that.
Thank you. I think I will just share a brief statement about mentorship because my colleagues have covered the vast majority of it. But I think the value of mentorship is overall underestimated and undervalued. And so as someone who has a mentor that I looked up to from a very early period in my undergraduate career, I can tell you that it plays a great role when we look at fit for purpose. It also looks at helping those that you mentor or the mentee to identify their purpose within the career and the fraternity of health in whatever shape or form that might take. So it has to have a much greater value attached to it because the impact of it is really tangible.
I think, Trev, we spoke about this the other time about how provincially we don't have much of a distribution of mentorship. So there's hotspots of academic learning. And these hotspots of academic learning in South Africa end up being those hotspots, and that's about it. But Eastern Cape, rural Northern Cape, Mpumalanga, not that there's medical schools there, but you have doctors there. So we are as much, the word elite, or rather the hotspots, do not filter down to those that are not exposed to it. So we have to find innovative ways of knowing who the doctor population is, which populations do they serve, and how best as the colleges of medicine, different forums, how we can engage with them. And that's another thing that's a major concern.
So I'll make a comment about the he for she. So in my program, we actually provide a stipend for the ladies, and if they have children, we give them an additional stipend to provide care for their children. One of the discussions we had was what happens if you get pregnant during training. And so for our training program, we allow them to graduate on time, so it doesn't affect career progression, but they still have to fulfill the time requirement. And I know that's a controversial discussion, which across the continent, different colleges handle it differently. And I know for COSEXA, you have to finish 3 years of fellowship or 4 years, but those non-spoken soft things is what affect the overall quality of training. Because it's interesting, all the female trainees who got pregnant and got this special consideration have actually stayed on as faculty, all of them, and now they're training others. And in Kenya, it was a very controversial argument we had for a long time. I think eventually we said each institution to follow the HR policies. But those are some of the questions as we think about medical education. And for young specialists who are in this, call it reproductive age group, and for the men, not to be left behind, because I got paternity leave. We tell the residents, you can't have too many kids, because if you add that paternity leave, it can come to a long time. So anyway, just to say that these small things actually contribute a lot towards the quality of training and the quality of the experience of training.
Yeah, and I think all of these, speak to essentially, humanity, right? We are people, we are individuals before our professions, and we shouldn't lose sight of that. And I think being in a profession shouldn't negatively impact you based on your race, your gender, your ethnicity. And these are the things that young specialists essentially deal with, essentially from undergrad days right up until when you specialize. And if you want to sub-specialize, you prolong that agony. So I do think that part of us as the young group is to obviously embody this image of humanity, and we know that in our college, we got on with the CMSA now as the People's College, and we think that the profession should also be in that, where people are able to be who they are and shouldn't be anyway disregarded. And I think it's just going to take us to the next issues of, how do we actually provide solutions in some of the other challenges that we've brought up. And we've thought about that, we need to make sure that, young specialists who are unable to stay within the public sector, who end up in private sector, need to have a link back within the public sector. And that's linking back to your academic institutions, and essentially the academic institutions where, I think it would probably be easier where you're trained, where you can still be in, whether it's an honorary role or whatever, where you still can come back and give back. And that can be in the form of, teaching students, taking through the young guys. But I think importantly now, if we have to address the issue of, the lack of skills training that was impacted by COVID, we do know that we've got a lot of, surgical backlogs, knees and hips. People are waiting at least 2 years for that. And we need to obviously come up with innovative ways in terms of how do we actually address that backlog. And I think if we've got a group of young specialists who have just completed, who are probably short on their logbooks on some of their procedures, and I think we do really could use that to our advantage to make sure that we address two issues. We address the issue of the backlog, and then obviously we address the issues of making sure that we're getting people upskilled. And then the other issues I'll pass on to Hlandra is to talk about the issue of private public partnerships.
I think many of us left the public sector not because we just didn't have posts. And I think there's a lot of us sitting in private practice who are really wanting to be great teachers and who are able to engage with young students. And what I found at VETS, there is a honorary, you can get an honorary post. It's a non-paying post, but you can definitely supervise master's degree, which I've done. And you can actually partake in external exam. You become an external examiner for undergraduate students, which is something that you can do. But also, more importantly, you can come in and actually do lecturing and mentoring. So the fact that you don't have a government post doesn't preclude you from the fact of obligations that you can actually be part of in the university setup. You can definitely be a mentor, and you can definitely do teaching. I think there's a lot of skill and brain drain or out from the public sector, but also just intellect also leaving the country because of no posts, etc. So my passion is make it transparent, make the availability of that possible interaction where someone from the private sector can come in and actually engage in public health, whether it be mentoring or tutoring or marking even master's degrees. There's so many things that need to be done from an academic point of view that it does not mean that if you don't have a government post that you're just an outsider. So I think that's something that I'm very passionate about, that not one teacher is great for every student. You need different types of teaching for you to actually grasp concept and be confident in yourself and be emotionally equipped to withstand. I mean, I did registrarship with 2 children. I had a young baby and I got another one in 2012, and I was a senior registrar. That experience, or how I did that, God knows, is only something that I can pour out to the next person that wants to do that. I wouldn't advise it. But my point is that there's enormous experience in mentoring, in teaching, and how did I fail that exam? I actually, in the second preparation, I did that. Maybe you should try that for yourself. Because it's not just about the book and the curriculum. It's about that whole registrar incepting all of that curriculum and being confident to say, look, after these 4 years, I am a very good consultant. I can do this now. I can do research. I can do everything.
Thanks very much, Hlandra. Inga, can you just touch on your experience on just collaborations from where you're at, And then Mike, just from your end.
Thank you. Yeah, I think in terms of training, it's absolutely essential to collaborate not only amongst yourself, so to remember that when you are a registrar in training, that you're not alone. So you need to make sure that you are a part of that team that's training and make sure you don't leave anyone behind. So like my colleagues also said, it's very important not to notice problems at the end, but to notice that some of your colleagues might be falling behind earlier on, and what can the group do to support those people to come along so that everyone at the end of the day reach the college for exams and hopefully pass. So the collaboration must be internal, but then external as well. So the external collaboration between universities, between disciplines, and internally could be within departments, and then externally between universities. And it makes a great impact because one university is really strong in one discipline or one element of a discipline, whereas the other is stronger in another. And so you have that knowledge sharing and that ability to learn from one another, and that grows and develops you in your field, and you are more equipped and better capacitated to reach a point of where you are a successful and a safe practitioner to go towards exams.
Okay, so I'm going to introduce a slightly different angle to collaboration. So in our program, we send our residents out for electives, and so they've gone to Cameroon, Niger, Sudan, South Sudan. So my point is, if we allow the younger generation, the younger specialists to go to these places, they are more likely to want to go and work there. Africa has got a gap in surgical provision and anesthesia and nursing. And I think one of the areas for collaboration would be, even as we have all the colleges here, how do we help younger specialists who are out and who haven't, in that phase where you haven't settled and you're thinking what else you want to do, they're usually more willing to go out. I know a program that sends newly graduated surgeons for 2 years. They fund them to go there. They place them. Importantly, they connect them to someone who helps them to settle in the new environment. I was in Namibia last year, and I met some of my colleagues, and they told me, if you know someone who's willing to come, it would be really nice for them to come and work out here. So that's one of the other solutions we can think about. If the colleges are willing to help place, and we know new surgeons who say, I would like to work in South Africa or in Botswana, and we can place them. That would be one active way that we can work on collaborations and linkages between ourselves.
And I think, that also speaks to the next point, which is the issue of decentralization in terms of, the healthcare as well as education. And I think as young specialists, I think we have an important role to play in being part of the change of the college, our college, when it comes to examination, teaching and training. And I do think that, we're never going to have enough money for healthcare. And we need to look at other ways in terms of how actually we can provide safe and equitable healthcare. And that basically means, you need to decentralize healthcare. We really should be, as young specialists, driving the issue of, limiting the flow of traffic of patients to the tertiary and regional hospitals. We should be doing outreach. We should be going to district level hospitals. We should be also, playing a big role in strengthening primary healthcare. I think, I shouldn't be able to, shouldn't be referring someone to you with a diabetic foot for you to take it off. And I think if we can actually, as young specialists, play a massive role in that, I do think that we will find that we will be able to make do with what we have. Dialysis and the access to such things in an African context is very, very limited. And it speaks again to the burden of non-communicable diseases and how do we actually address that. And I really do think as young specialists, we actually need to just flip the model where we actually go out and deal with problems, straighten primary healthcare, collaborate, support our family physicians to make sure that we actually limit the flow of traffic to going in. And I think in the other massive issue that hasn't really been touched on, and that I think is also not really taught well, that has also an impact in the training, has an impact in mental health, is the whole issue of how do we actually deal with the actively dying patient. and that speaks to the issue of palliative care. And I think it's an important concept that I think from an African context that we really should be, looking deeply into it. We had an eloquent presentation from the Society of Oncologists yesterday, and we had the stats about how many people in this region are going to end up with cancers. Majority of those people are going to pass on, and the question, begets, in a healthcare system that's full of challenges, how do we actually deal with actively dying patients? And this is in palliative care, cuts across all disciplines. And I think it also plays into your role in terms of how many resources you would allocate and you should allocate. And I think we really need to introduce that. We need to train students, we need to train registrars, and importantly, we need to train consultants when it comes to palliating patients. And then from there, we can only train and assess and obviously make sure that the families, we can be able to provide that element of care. And I don't think that we have that enough. And I think that it's something that we really, really need to focus on in an African context. And I like the other presentation earlier on about, transplant medicine in an African context. We read about all of these things. These are options, these are treatment options. But how do we actually, facilitate and engage them to make them work for us? We've got massive cultural barriers. It's very easy to find any organs in Africa, and it's a big cultural barrier. So I think all of those things are things that we would like to propose in terms of as potential solutions. We are very grateful to have been part of the forum. And I think there's a lot of wisdom that has been shared over the past 48 hours. And, just listening to the various colleagues, and, it's been very inspiring. And, we are actually seeing that in as much as we thought that we need to reinvent the wheel, but actually no. I mean, some of the solutions and some of the issues, we've got, our colleagues here who have actually walked the path, and we just essentially have to just tweak it and make it work for us. So in closing, just to make sure that I don't go over time, I'd just like to thank my panelists. I think thank you. It was really, really wonderful meeting and getting on to doing this together. And I'd just like to thank the organizers for allowing us a seat at the table. It really is something that is worthwhile, and we've had a lot of take-home messages. And we thank you for being with us. Thank you for listening to us. Thank you.
Thank you very much. So we'll take a picture for this panel because I know people are leaving as well. Well done to our young specialists. Can we please give them a huge round of applause? They have a nickname for me. They call me the Queen Mother. But I think since I'm the immediate past president, I'm more the Queen Grandmother now. So colleagues, it gives me great pleasure to welcome our CEO of the Colleges of Medicine of South Africa, who you may have seen walking around, Professor Eric. Hey? No, we didn't see that. And so he will just give a brief 5 minutes in terms of the recommendations that we're going to have. And then after that, we're going to be handing out gifts to our visitors from the African colleges together with Professor Rana. I do plan, so please don't be anxious, I plan to stop at 4 o'clock. Because even our president has to leave by 4 o'clock. Thanks. Over to you, Professor Buch.
So, colleagues, I can say colleagues because I am a fellow of the College of Medicine of South Africa. So, what we've been sort of working towards is that my sense is it's been an exceptional experience for all of us here. And we can go away with that in our back pockets. But part of a sort of broader idea is that we want to influence and impact the space of medical specialists on the continent in all its dimensions, from access to wellness to educational opportunities to assessment. And there's been a lot of discussion about how to take that forward. And we're really looking at probably two key products. The one is a conference report. And there we're looking at whether it's 45 or 60 or whatever pages, and we've had our report writers here capturing the essence of all the presentations, all the discussions, and we're hoping that that report will become almost like the benchmark report around taking forward medical specialist practice on the continent and making it universally accessible to all our people. And that no one will talk about medical specialist issues on the continent without referencing the report of IMELF Africa 2023. So that was the one dimension. The second dimension is whether it's a letter, a call to action, a pledge. We've heard a lot of those words. And we've been working to try and distill out some of the key messages. The detail will be in the full report. And so we've been working with Dr. Sayendra Moodley, who's the president of the College of Public Health Medicine here in South Africa, together with our report writers. And what we've handed out to you now is not a polished end product. I mean, it's not possible for us to have captured the vibrant discussions in the leadership breakaway and in the examination and assessment breakaway and incorporate it in here, and we can't capture some of what came out of the young leaders panel as well. And so if you look on the back of the second page, we've got here add actions on leadership and examination assessment, advancing young leaders' development and role. But we wanted to get a sense from you whether we're on the right track. Because the plan is, if we're on the right track, we're going to email this out to all our participants, invite your comments and feedback over the next week. We'll get it out probably on Monday. Ask for comments back in about a week later. Try and incorporate and distill those comments and send it out, depending on how much we have to revise and revise. We may send it out for a second round of comments and then afterwards for endorsement. And then the idea is at the end of this call to action, as we've called it here, or letter or pledge, the idea is that we will put all the participants who've agreed as signatories to this. So we will list, the president of the College of Surgeons, Dr. Jane Fuerlal, president of the College of Surgeons. And so all the names will be there from IMELF Africa 2023. So we don't have the time because you've heard that we're on a strict time scale. So I can tell you in global meetings of WHO, when they have a draft like this, Francis, I would say they set aside the whole day and they have debates and then they're going to Cork, come back, and even longer to pull to get to the final point. But I think we'll communicate electronically. You have my email and my phone number. If you want to chat about certain concerns you have, we'll set up a Zoom call with or Microsoft Teams call with myself and Sayendra and chat it through with you and maybe Flavia as well, if you think we need to make big changes and move it off. But what we wanted to do is just to say that we thought that we would point out who was at the meeting. We said, we note, we're aware, we're concerned. That's to give the context. We weren't sure whether to put some statistics in, about the huge shortfall, like, less than 2% of kids needing cardiothoracic surgery get it within the first 2 years of life, that kind of thing. So we've got this where we've sort of noted, we've used different phrases, and then we go in, it maybe should have been bold, we call on all stakeholders to become involved in a vibrant movement to achieve universal access to specialist medical care in Africa and to commit to the following actions. And then we've defined the actions around the core themes that both of the conference as well as that have emerged in the deliberations and the presentations. So to retaining African-trained specialists on African soil, to increase the number of specialists that we produce in Africa, to empower other practitioners to advance in a referral network to specialist care and to work with us. There was quite a lot about that. To improve integrated wellness of specialists and to realize their full potential. And then we want to add on examination assessment and on leadership and on the role. We'll work out exactly what order it's best to place these in. It doesn't have to be the sequence of the conference, but the order of it. And then, there was quite a lot of discussion, especially in the last two breakaways, about a pledge or establishing. And so we haven't quite tweaked it out yet as to how to deal with the conclusion, where we've said, in conclusion, as participants in IMELF 2023, we pledge. So there's a call to action where we call to colleges, we call to deans and universities, we call to governments, and we are the colleges, we are the universities, but somehow there was a sense that there should be a pledge from the participants of this IMELF forum. And so we just pulled out three big messages. We may again tweak them, but one was to advance leadership as a pledge around medical specialists, the Pan-African working group that was described, and that was to look at novel areas of collaboration in education related to assessment, examinations, tools. And the question is, should we keep it to examination and tools, or should it be a wider collaboration, one component of which is that? And then we, because it's a pledge to play our individual and collective part in realizing the goals spelt out in this call to action. So that's really what it is. It's an unfinished piece of work, as you would expect. What you usually have, as Francis will say, is that we did a few of these when I was a NEPAD health advisor, and Francis was leading some of the global challenges, and I'm sure many of you others, is that the kind of thing you'd have now is you would adjourn for the day, you'd have a writing team going through till about 3 a.m., Stella's laughing, ready for everyone to come back tomorrow and spend the morning debating the text. So we're going to skip that part and not keep you here till tomorrow lunchtime, but rather try and do that element of it electronically. So that's what we're thinking, and we were hoping that while I was talking, you'd had a chance to glance and browse and give us a sense of whether we're on track. The detailed review, you'll get back. So Helene will email this out to everybody, and that's when we'll get the detail. But is this the kind of output that makes sense to you? I think that's the big question, because if it doesn't and we need to throw it out, then you need to tell us what we need to produce instead. Thanks very much. So Indra, I don't know if you're happy that I've captured this. Yes, while this was going. Yeah. So we may still polish it over the next couple of days a bit before we send it out. So what you get will not be this. The problem that we faced was that the team was working on the missing parts, but we also wanted to make a hard copy to give you. And so you can't do both at the same time during the sort of last session that we had. So this is not, as you correctly say, the latest version. I don't know if you want to get
Thank you very much to Professor Buch and Dr. Moodley. Dr. Moodley doesn't want to come and sit here. He's supposed to sit here as well. So colleagues, is this kind of, as Eric was saying, is this kind of the flavor that you want? I see nods, nods, nods. Okay, great. So maybe, Eric, I was thinking as I was sitting there, maybe we should have another Zoom meeting, following on what you were suggesting in terms of the way global meetings are done. So we can have a Zoom meeting for all the colleagues again, and then do a proper presentation, even if we spend maybe 2 hours on it. And then after that, get comments, and then polish it up. So colleagues, as Eric was saying, we we have about 3 outcomes from this meeting. We've got the big report that's being written by our conference writers. Then we've got this call to action stroke letter. But another recommendation, Eric, that has come out strongly was the recommendation around the letters, the letter from the elders. So I think those are kind of 3 things that are coming out. I don't see any comments, colleagues, so maybe, yes, please go ahead.
Thank you. Can we please consider putting some statistics to back this up? Because as it is, it's plain. Of course, it's still work in progress, but I'm also proposing that we put some data to back our statements. Thank you.
And I'll be that like the professor that I am and say, since you made that suggestion, we'll rope you into the team as well with Eric and Sayendra.
It's okay.
Is it okay?
I was part of the rapporteurs, so
Great.
it's okay.
There we go. So now hopefully I haven't made people, and Prof. Maso as well. Yeah.
Just to put this on the table, I'm not asking for any responses now. We are using the word medical specialists. I don't know whether we would not be making more mileage if we replaced it with health. Just for consideration. It occurred to me from the very beginning when I heard about this meeting.
So Francis, I think, you know my history and work with community health workers and others, and the idea of interprofessional and the whole health worker pyramid. The tricky part that we had in when we thought about that is that because this, the Royal College of Physicians of Canada started essentially a college of medical specialists. And IMELF has traditionally been a forum coming together of medical specialist colleges and related colleagues like deans of medical schools, and focusing on medical specialist issues. So even though it's called Medical Education Leaders Forum, it probably should have called Medical Specialist Education Leaders Forum. There's a missing S, I suppose, in the title. So the problem that we had is if we put health professionals, then the question is going to be, why weren't we there? And then the nurses will say, but you're talking about health professionals, but you never invited the nursing specialists, and others. So maybe what we have to do is capture that breadth. And it came up in quite a lot of the discussions, saying, unless you have, for example, the specialist nurses, the ICU nurses, the theatre nurses, the anesthetic nurses, and so on, medical specialists are not going to be able to express themselves fully in their practice and be successful. So maybe we've got to find a way of blending that in, sort of in a stronger way. I don't know if you'd be happy with that. In terms of, I'm sorry, I'm calling people by their first names. I hope you don't mind, but Stella is extraordinary at drafting documents. In the few months I've known her, I've seen a couple of astonishing documents come out. So it's a good addition to the team. But what I was thinking, and these are formative thoughts, is that when you finally put this out, you don't put it out as a blank document like this. You put it out in a kind of more like I don't want to call it an advertorial, but as an advocacy document. And there are tactics in advocacy documents in what you bold and where you make big font. But you also put in a few little squares or bubbles or whatever you like to call them with big punchlines that are big takeaways to which that's there. And I think maybe a few of the statistic kind of items, rather than putting them in the text, or maybe part of the actual, call it leaflet, pamphlet document that goes with it. The idea is that this document will be at the forefront of the report. So it'll be right at the front of the report. And then the detailed report will follow, but it will also be a document of its own. And I think the idea that we have, and again, you'll guide us on where to send it, we'll share that with you. But you see, we think that we want to distribute this document very widely. So we want to send it to colleges around the world, include some of the message of what Johan asked yesterday as well about international practice of colleges and so on. So we'll send it to sister colleges or fraternal colleges around the world. We'll send it through the African Medical Schools Association to their mailing list of African medical deans. We'll send it to all the ministers of health of Africa, potentially through the African Union Commission. We'll send it to WHO. We'll send it to WFME, the World Federation of Medical Education. So we want this, we will send it widely. We'll have both some hard copies, but we'll have a polished electronic copy that's properly published that can be distributed and downloaded. So that's the intention of the spread, to gain momentum. And then there was the talk of the advocacy and follow-up on that. So I think that there is a global health workforce forum, the 5th Global Health Workforce Forum. Francis organized the first one in Kampala, and that'll be in Geneva in early April. It's a bit of a change, as we were discussing over lunch, Francis. It's a kind of change thing. It's become like an intergovernmental meeting, more than in Kampala, you had what, 10,000 people, I think it was it? It was extraordinary, from across health workforce leaders, advocates, teachers from across the world. But we're going to try and get a table there. We're going to try and see if we can get a slot at either at the WHO Regional Committee for Africa meeting of WHO, which is once a year, try and get a slot in their panel, as well as in or at the African Union Health Ministers meeting. So we'll do those things, but I can see Johan is getting itchy because I suspect he's worried he's going to miss his flight. But if people have ideas who else to distribute to, what else we should do, how we should pitch it, this is a collective effort, and we're receptive. We're not saying we've got the answers.
So we're going to now hand out the gifts, and Eric will just yeah. So then Eric is going to just assist us in terms of handing out, and this really is just a small token of our appreciation for especially our guests who have traveled from far and wide. For the South Africans, we're going to have a braai maybe. We'll ask our president, our braai and wine, so please don't worry. And so we'll start off with Professor Jane Odubu, if you could just come up, and then followed by Professor Chite Ashira. I think he may have already gone, so we will just send that to him. Professor Peter Donko as well, if you can just come up. And Dr. Alex Coutinho is not here, and then Professor Maudet Rana, Ms. Stella Itungu, Dr. Tamara Piri, Prof. Owatokwa Nomazama, She's here. And then Prof. Francis Hamasa, Prof. Aliedin Ahmed, and then Prof. Damali Nakanjago, and then Prof. Philip Mushembelwa, and then Dr. Michael Wachira. Yeah. Yes. Prof. Jane. So thank you very much, colleagues, and then I'll hand over to our president.
Right, Jeanette, we get through this in no time. So firstly, Eric, can we have the staff inside? Are they going to come through? Are they all at the back? Do you want to come down? Yeah, I do. But I'd just like to start just by thanking all the staff from the CMSA and from the University of Pretoria, who laboured so hard to make this Congress to work so smoothly. And I'd like us all to give them a big hand of applause. Thank you very much. We're going to take a photograph. Come. Congratulations. Harleen, just stand here. And and I'd like us to give Harleen a special applause because she really worked hard and made things work beautifully. Thank you very much. Okay. It's been a great privilege for the CMSA and IMELF to host such a wonderful meeting meeting of minds on leadership for wellness and success in Africa in healthcare. And if I can just mention that Trevor Mguni, who from our Young Specialist Committee, he just remarked yesterday to me how impressed he was with the collective wisdom and the wealth of experience in the room that was represented from Africa, and I can support that most certainly, Trevor. While Africa and low middle income countries need to leverage expertise and practices from high income countries, we need to find our own context-specific solutions to our challenges in Africa and elsewhere. And we do have the expertise to do that. We heard about that today, and we witnessed that over the last two days. I therefore look forward to more South-South collaborations, also with Pakistan, to address our challenges in the lower and middle income countries that, after all represent 80% of the world's population. So this is really where the major challenge is in healthcare in the world. So I'd like to thank you all for sharing your wisdom and your experiences and your perspectives with us over the last 2 days. And I wish you all a safe journey home. And I look forward to creating a Pan-African forum or fora to enhance leadership and wellness and training and assessment and of course, access to care. So safe travels, and thank you very much.
When your leader is spoken, you're not supposed to add anything else. Colleagues, I'll just then, for what's left for me, what a great honor and privilege it really was to chair this meeting as the grandmother of this college. And we adopted during our presidium with Johan the slogan that this really is a people's college. And I think IMELF Africa is a real people's meeting, and I hope that all the recommendations, as Eric and Stella and Sayendra are putting together, that they will become that. And so with that, colleagues, please have safe travels. Hope you take lots of pics before you leave. And to our president, we're just so deeply grateful for the leadership that you give to this amazing college and to ensuring that we have this kind of function. And really, I think it's a testament to the amazing work and collaboration that you not only do in your personal capacity, but for the entire country and the continent. So thank you very much, colleagues. Have a safe travel.